Assalamu alaikum. Our lecture today is on cardiac biomarkers. Coronary artery, it's the main blood supply for both ventricle, right and left ventricle. Arterial atherosclerosis, it's the main cause of decreased coronary blood flow. Symptoms of coronary artery disease, it starts from severe chest pain, which is stabbing or squeezing pain, start in retrosternum and refer to the jaw and to the left side of the arm. It may be associated with nausea, vomiting, and headache. One of the important investigations for diagnosis of acute myocardial infarction is ECG. Early, there is an raised ST segment, late depressed ST segment, and inverted T wave. Biomarker, it's a chemical substance used as indicator for biological state. There is three criteria for biomarkers. First, it must be accurate. Second, reasonable cause. Third, must provide an additional information such as diagnosis, prognosis, and follow-up. Historical of cardiac marker. The early cardiac marker discovered is in 1954, which is SGOT or aspartate transaminase. The later one in 1992 is troponin I. Classification of cardiac biomarker. It's biomarker for myocardial injury as marker for myocardial necrosis, marker for myocardial ischemia, biomarkers of hemodynamic stress as natriuretic peptides, and inflammatory and prognostic biomarker as C-reactive protein, myeloperoxidase, and homocysteine. Biomarker of myocardial injury as CK, and the most important isoenzyme is MP, which is specific for acute myocardial infarction, lactic dehydrogenase, aspartate transaminase, GOT, serum glutamyl, oxaloacetate transaminase, myoglobin, and cardiac troponin. In myocardial infarction, there is two different zones: zone of infarction surrounded by zone of ischemia and separated by zone of injury. The first biomarker in acute myocardial infarction is creatine phosphokinase, which is called CK. CK enzyme is used for phosphorylation of creatine to creatine phosphate, which is used as a source of energy in myocardial muscle. CK is highly specific for cardiac tissue. It began to rise later from 4 to 6 hours after the onset of infarction, reach peak within 12 hours, and return back within 48 hours. It be used mainly to indicate reinfarction if its level returned back to normal and then increased again after that. Drawback of use creatine kinase as a biomarker is a false positive elevation can be seen in significant skeletal muscle injury, especially after injection after intramuscular injection, also in cardiac injury for reasons other than myocardial infarction as defibrillation, blunt chest trauma, and cocaine abuse. There is three CK isoenzyme: CK1, CK2, and CK3. The most specific one in acute myocardial infarction is CK2, which has two subunits, M and B subunit. CK-MB isoenzyme, remark, it is an isoform and may be also be analyzed using high voltage electrophoresis. Also, this CK-MB isoenzyme has two also different isoenzymes, which MB2 and MB1. MB2 is released from the heart muscle and converted to MB1. MB2, when it's elevated more than MB1, this is an indicated that it's an acute myocardial infarction. So MB2 must be more than MB1. The second cardiac biomarker is seromyglobin. Seromyglobin is a small-sized heme protein found in all muscle, mainly assists in oxygen transport inside the muscle. It's released from damaged muscle tissue, especially myocardial or skeletal muscle. It increase often occur more rapidly than troponin I and CK. It's released from damaged tissue very early, within 1 hour, and return back within 12 hours. So it appear early and disappear early. Condition for increase in myoglobin: acute myocardial infarction, skeletal muscle damage as muscle dystrophy, inflammation, myopathy, renal failure, severe uremia, and shock. The useful for assay serum myoglobin is it's a very early predictor of myocardial infarction used for thrombolytic therapy. So the thrombolytic therapy must be taken for acute myocardial infarction patient within 6 hours after myocardial injury. But there is many drawback for serum myoglobin, which is poor specific, very rapid metabolize, and early disappeared. Myoglobin level does not utilize often for diagnosis of acute myocardial infarction or myocardial damage assessment. The third and most important one for diagnosis of acute myocardial infarction is cardiac troponin. Cardiac troponin protein is a complex of 3 regulatory proteins that is integral to non-specific muscle contraction in skeletal as well as cardiac muscle. Troponin is attached to tropomyosin sitting in the groove between actin filament and muscle tissue. Troponin has 3 subunits: troponin C, troponin I, and troponin T. Troponin C has calcium binding ability and has no diagnostic value, and so it's not used for diagnosis of acute myocardial infarction. But the other two, which is troponin I and T, it's used for diagnosis of acute myocardial infarction. Troponin T binds to troponin tropomyosin complex. Troponin I, which is an inhibitory protein, stop actin myosin interaction. Troponin I isoenzyme is a cardiac muscle protein with a molecular weight of 24 kilodalton. It has an additional amino acid residual on N terminal that are not exist on the skeletal form. The serum level of troponin I start to rise from 2 to 8 hours. Troponin T is another isoenzyme of troponin protein. Is present in the fetal skeletal muscle, but in healthy adult skeletal muscle, troponin T is not present. In the gene of troponin T may be exist in skeletal muscle disease. Biological half-life and the early serum increase in troponin T are similar to that of troponin I. Troponin level normally it's less than 50% in the cytosol. Troponin level began to rise 2 to 3 hours after the onset of myocardial infarction. Elevation of troponin I and T can persist for 10 days after acute myocardial infarction, so it starts to be raised very early and completely disappear within 10 days. Thus, the studies have failed to find a source of troponin I outside the heart, but have found some troponin T in skeletal muscle. So, troponin I it's more and more specific than troponin T in diagnosis of acute myocardial infarction. There are many conditions commonly associated with increased cardiac troponin, for example, arrhythmia, congestive heart failure, coronary artery disease, coronary vasospasm, critically ill patient, hypertension, myocarditis, pericarditis, pulmonary embolism, pulmonary hypertension, renal failure, sepsis and septic shock, sepsis-related myocardial dysfunction, systemic inflammatory disease, and trauma. Troponin I and troponin T raise 30% or more within 6 hours from chest pain. This is a diagnostic of myocardial infarction. If troponin I raise more than 1 nanogram per milli, this means that very large myocardial infarction has bad prognosis. So, in addition to troponin I is more specific, it's more prognostic. Lactic dehydrogenase enzyme. Lactate dehydrogenase enzyme, it's an reversible enzyme that can form lactate from pyruvate and vice versa. There are different types of lactic dehydrogenase enzyme from 1 to 5. The most specific 1 and 2 for diagnosis of acute myocardial infarction. This is an electrophoresis figure for lactic dehydrogenase isoenzyme. The most prominent lactic dehydrogenase isoenzyme in normal person is lactic dehydrogenase 2. But in myocardial infarction, the most prominent one is lactic dehydrogenase enzyme 1 and 2. So, after myocardial infarction, as we said, lactic dehydrogenase 1 and 2 is the most prominent subtype. In acute viral hepatitis, lactic dehydrogenase 4 and 5 are the most predominant. So the total lactic dehydrogenase frequently elevated in many neoplastic disease. For example, lactic dehydrogenase 2 and 3 in leukemia, lactic dehydrogenase 2, 3, and 4 in case of cancer testis and ovarian cancer. Increased lactic dehydrogenase 5 in breast cancer, malignancy of CNS, and prostatic carcinoma. The last cardiac marker is aspartate transaminase or glutamate oxaloacetate transaminase. Aspartate transaminase is a transaminase enzyme that can transaminate the amino group from aspartate to alpha ketoglutarate to form glutamic acid and oxaloacetate. AST is present intracellular in both cytosol and mitochondria of the cell of myocardial and liver mainly, but also in the muscle, pancreas, and the kidney. Normal level of AST is less than 40 international units per liter. It increases in myocardial infarction within 24 hours and also in liver disease, muscle disease as muscle dystrophy, myositis, acute pancreatitis, and after prolonged severe exercise. The first cardiac marker raised after acute myocardial infarction is seromyglobin, followed by troponin T or I, then creatine phosphokinase MP isoenzyme, aspartate transaminase, and lastly lactic dehydrogenase enzyme. Thank you.